one platform. Thank you for joining us for today's webinar. Hope you all have a fruitful session ahead. May I invite Elizabeth Varghese, faculty from Department of Clinical Nutrition and Dietetics for the welcome address.
A warm namaste to all dignitaries and participants who have joined for today's national webinar on the topic, Take Action for Bone Health, conducted by the Department of Clinical Nutrition and Dietetics, St. Teresa's College at Natalie, in connection with World Osteoporosis Day 2021. Let me at the outset welcome Reverend Dr. Sister Vinita CSST, Provincial Superior and Manager, St. Teresa's College at Natalie, Reverend Dr. Sister Emmeline CSST, Director, St. Teresa's College at Natalie, and our Principal, Dr. Lizzie Matthew, in their absentia. I deem it a privilege to welcome our keynote speaker for the day, Dr. Ronsi Xavier Kuruvilla, Assistant Professor, Department of Orthopedics, CMC Vellore. In spite of his busy schedule, Doctor has found time to impart his knowledge to each one of us. It is an honor to have you in our midst, sir. A very warm welcome to you, sir. With great pleasure, I would like to welcome Mrs. Lekha Srinivas, Women's Study Center Coordinator, our pillar of support in all our endeavors. Welcome, ma'am. Let me take this opportunity to welcome Mrs. Annie Thomas Totan, Head of the Department of Clinical Nutrition and Dietetics. Welcome, ma'am. I would also like to welcome all my dear faculty members and students to this webinar. A warm welcome to all participants from various institutions who have eagerly joined for this webinar with us today, even amidst your busy schedule. We hope this webinar enlightens each one of you to serve up for bone health. Once again, welcome one and all. Thank you.
Thank you, Elizabeth. Let me take this opportunity to welcome the Honorable Resource Person, Dr. Ronsi Xavier Kuruvilla. Doctor, after obtaining medical license, took up practice as a casualty medical officer at a leading trauma center in the state. Attendance of the emergency procedures and trauma further developed interest towards orthopedics. Joined as a junior resident for DNB Orthopedics at Lourdes Hospital, Kochi, being a leading orthoplasty and orthoscopic center in Kerala, Kanyan Doctor has adequate exposure in orthoscopic procedures of various joint and joint replacement. After completion of training, Doctor joined as a senior resident in the Department of Orthopedic at Christ Medical College, Vellore. At present, Dr. Ronsi is working as an assistant professor in the Department of Orthopedics at Christ Medical College, Vellore. Dr. Ronsi has won the award for the best performance at the ITLS course held on February 2014 and also have various publications onto his credit. I now invite Dr. Ronsi Xavier Kuruvilla for the presentation. Over to you, Doctor.
Thank you for the warm words and welcome. At the outset, I'd like to thank my dear friend Annie for giving me this opportunity and for inviting me for this talk. And I hope I can do justice on this topic that we've picked out for today. I'll move on to the topic and I'll share my screen. Is the screen visible?
No, not yet. The presentation is not on, I believe.
All right. Now?
Yes, it's visible now.
All right. Shall I start?
Yes, please.
Good evening, everybody. So we'll talk about osteoporosis, and being the osteoporosis week, I think it's apt that we did pick this time to talk about it. I'll start with like an idiom. To succeed in life, you need three bones: a wishbone, a backbone, and a funny bone. To define osteoporosis, it's a medical condition in which the bones become brittle and fragile from the loss of tissue, typically as a result of hormonal changes or deficiency of calcium or vitamin D. WHO gives a definition where the bone mineral density is 2.5 standard deviations or more below the mean for the young, healthy adult of the same gender. It's a systemic disease, much like any systemic disease that we have, like diabetes or hypertension, where the musculoskeletal system is involved. It leads to low bone density, microarchitectural deterioration of bone tissue, leading to bone fragility and increase the risk for fractures. Now, in the world, around 1 in 3 women over the age of 50 suffer from osteoporosis, and 1 in 5 men over 50 suffer from it. As you can see, the microarchitectural composition of an osteoporotic bone differs from a normal bone on the left side. We will have a brief talk on the bone metabolism, which I'm sure all of you know. Bone is a living organ, much like any other tissue in the body, and it is involved in a lifelong process where the mature bone is removed from the skeleton and new bone is formed. The composition of bone, it has both organic and inorganic material. In the extracellular matrix, it's composed of both inorganic and organic. The large amount of bone, as everyone knows, is inorganic, composed of calcium hydroxyapatite. And the organic materials include type 1 collagen, which is the main contributor for the bone strength and elasticity. Other substances like proteoglycan, osteocalcin, growth factors, and cytokines, which are involved in the bone metabolic processes. All these are carried out by cells which have specific functions assigned to them. These cells include the osteoclast, osteoblast, osteocytes, and progenitors. So all cells in the bone are formed from progenitor cells, which later evolve to osteoclast, osteoblast, or osteocytes. Now, the specific function of these cells, briefly, if I would mention, osteoclast is involved in bone resorption or breaking away of bone. Osteoblasts are involved in laying down of new bone. And osteocytes are the cells which form the bone architecture. And progenitors are the cells, like I mentioned before, from where all these cells derived from. Now, the inorganic material, which is composed of 60%, is mainly calcium hydroxyapatite. And therefore, we know the importance of calcium and bone. Calcium is in a recommended dietary allowance in adults is around 1,000 milligrams per day. It is increased in conditions like pregnancy, lactation, and postmenopausal to 1.3 grams per day. Children, infants would need a much lesser, 300 to 500 milligrams, and children of various age groups would have an increasing requirement as they grow. Now, the plasma concentration of calcium is how we determine whether there's adequate calcium in your blood. So in a blood test for a serum calcium would give a normal value of 8.6 to 10.3. But not all calcium in the blood is in the active form. It has to be in the ionized form to be active to carry out its various purposes. So the ionized value is 4.5 to 5.6. Now, a brief talk about the homeostasis of calcium, which I've been asked to touch briefly on. I'm sure all of you would know about it. So if the blood levels are normal, your homeostasis is maintained by this cycle. A fall in the calcium level would stimulate the parathyroid glands in next to your thyroid to secrete parathyroid hormone. The function of parathyroid hormone is to increase the serum calcium levels. It gets its calcium from the various sources. One being the kidney, so that it reuptakes the calcium that is filtered out in the urine. And the other way is by breaking the calcium in the bone to release it into the blood. And this calcium, which is uptaken in the kidney, is also by the active form of vitamin D allows the uptake of calcium from the gastrointestinal tract as well. This effectively raises the calcium level. Now, if the stimulus is a raised calcium level in the blood, instead of the parathyroid hormone getting activated, it's a calcitonin, which stimulates the exact opposite. That is more deposition of calcium into the bone and a reduced uptake of calcium in the bone from the kidneys. Vitamin D, the active form, is required for the functioning of for the uptake of calcium. Vitamin D is largely derived from the exposure to sunlight, specifically UVB sun rays on the skin, which converts a steroid present in the skin, 7-dehydrocholesterol, to its to convert to its active form. This requires two enzymes in the liver and then in the kidney to become the active 1,25-dihydroxy cholecalciferol. Coming to the classification of osteoporosis. Largely, a reason for osteoporosis which is not known is classified as idiopathic. Most people would say that if you don't know the reason, it is an idiopathic reason. So that's an easy way of getting out. Then the other types are, the most common one is the type 1 postmenopausal osteoporosis. This affects females usually aged around 50 to 70, and it's related to the loss of estrogen's protective effect on bone. And it results in trabecular bone loss and some cortical bone. So when we describe bone architecture, like we say, has two types of bone. They have two types. It is the cortical bone, which is the hard outer covering of the bone, and the trabecular bone are usually at the ends of these of the long bones, where it's also called spongy bone. So they actually look like a sponge, and they are much less they're less stronger than a cortical bone. And in postmenopausal osteoporosis, we find that vertebral fractures and wrist fractures are more common. The other type are the senile osteoporosis, which occurs commonly between 70 years of age and above, which includes both the trabecular as well as cortical bone loss. So when you have cortical bone loss, you see more of diaphyseal fractures, meaning fractures which are not only limited to the ends of the bone, but as well along the midway of the bone, that is the diaphyseal area. So the ends of the bone have been defined as epiphyseal and metaphyseal, and diaphyseal being the middle area of the bone. So you see more fractures because even cortical bone, which is more pronounced in the diaphyseal area, even they are also lost in senile osteoporosis. Now, these are primary, what I described earlier was the primary osteoporosis. Now, secondary osteoporosis is a deficiency in the calcium or vitamin D metabolism due to any other disease. It will lead to a secondary osteoporosis. We have a multitude of disease, which include the endocrine and metabolic disorders, collagen disorders. It can be even medication induced, such as long-term use of phenytoin or sodium valproate used in seizure disorders, or even glucosteroid intake. Then naturally, deficiency in the nutrition can lead to secondary osteoporosis, as well as certain malignancies and hematological disorders. Now, to describe osteoporosis or to know osteoporosis, there are a few terms that we have to know. There's a term called the peak bone mass. Now, it is the maximum mass of bone is achieved by an individual at skeletal maturity, typically around the ages of 25 and 35. After peak bone mass is attained, both men and women lose bone over the remainder of their lifetimes. Sad as it is, we all start losing bone strength after attaining peak bone mass. So any disease or any cause that can affect your peak bone mass will already leave you at a disadvantage to having poor bone health in the future. And if you see this graph, peak bone mass has a uptrend as you grow and age, and reaching bone maturity around 25 to 35 is your peak bone mass, which is usually higher in males than in females. And then subsequently, we start losing bone strength, and it becomes even more pronounced in women who have crossed menopause due to the loss of the protective effect of estrogen, leading to a further decline in bone mass and hence osteoporosis. Now, bone, like I've told you, is a living organ like everything else in your body, and it is a continual process where bone is laid down and broken down. And the function of these cells specifically, which I've told, was osteoblasts and osteoclasts. Now, the bone remodeling procedure usually goes through this cycle. Your osteoclasts are activated by precursor cells or signal. Then the osteoclasts secrete substances which help in the erosion of bone. And then there is surface preparation for the laying down of new bone, and then which is done by the osteoblasts. And once new bone is formed, it remodels and mineralizes to form the new bone. Coming to the clinical presentation of osteoporosis, mostly it is asymptomatic. People usually do not suffer from any obvious symptoms, even having had osteoporosis set in years ago. On the other hand, it may be asymptomatic, and on the other hand, you can have symptoms which include common clinical presentations like increasing dorsal kyphosis. So kyphosis is the normal bend in your spine in the upper and mid vertebral level, and due to the loss of bone mass and strength, there is an increase in the dorsal kyphosis. And as you can see the picture of the old lady, she has a bend forwards, which increases with loss of bone structure. And the hallmark of low bone mass is a low trauma fracture. And due to the loss of bone height, you can have loss of loss of height of the individual. And all this can be combined with back pain. Now, in the absence of fragility fractures, which is the hallmark of osteoporosis. The gold standard for the diagnosis of osteoporosis remains the measurement of the bone mineral density using the DEXA scan. I'll uh, I'll talk to you briefly on what the DEXA scan involves. Then there are that is the gold standard for the diagnosis of osteoporosis. We have other tools that help you, like a plain X-ray, which most often and most commonly it is done in most of the outpatient departments. And there are fracture risk assessment tools, which is actually a complex program um, invented by the Sheffield University in the US, and it involves a lot of algorithm, and it is not commonly used. However, I mean, in the Western side, it is quite commonly used, and it gives you a risk assessment of your bone health and your chances of fractures, fragility fractures. Now, DEXA scan is a dual energy X-ray absorptiometry, and it is a test which involves a machine that uses X-ray at different wavelengths, and you'll be hitting there'll be specific favored sites where we measure it, including your wrist, the vertebrae, the pelvis or the hip bone, and calcaneum or the heel bone. So these are the specific sites where we measure the bone mineral density using the DEXA scan. It uses two hit of X-ray, which have different wavelengths, and you measure the amount that is absorbed back. So the more dense your bone is, the less X-ray will be read. The less dense your bone is, the more will be read, and therefore that gives you the value. And this value that we get is measured against the normal for that gender, and it is also age specific. And the T-score is calculated for the same gender, a young individual of the same gender, and we get scores which are matched against the age-specific group, and that will give you the Z score. So a value less than, not lower than 1, -1 is normal. Between 1 and 2.5 is osteopenic, which means a decrease in the bone density, and less than 2.5, as WHO mentions, it's defined as osteoporosis. So as I said, FRAX is a tool that it evaluates your 10-year probability of hip and major osteoporotic fractures. And it's a very complex program, which most people don't use it, unlike unlike in the West, where it is quite common. Now, I told you the most common thing that we do to screen patients who have osteoporosis or suspect osteoporosis is our trusty old X-ray. So there are indications where you take an X-ray to either diagnose or to confirm your osteoporosis. Women aged 70 and men over 80, if you have a BMD score of the spine, hip, and femoral neck less than 1, have to have mandatorily yearly checkup with the vertebral imaging or an X-ray. And 65 to 69, if this T score is below 1.5. Now, what do you see in a conventional radiograph? So, the picture of where the T score is between 1.5 and 1 and 2.5 will show you a generalized osteopenic picture where the bone becomes less obvious on an X-ray. It's almost like a ghost-like appearance where the the ends of the bone are more clear, but in between the ends, it is almost hollow and black. Then there is a thinning and attenuation of the cortex. Cortex are the end areas of your bone. You can see these white lines. That's your thinning and attenuation of the cortex. That is what we call the cortex. And then there are signs there where there is an accentuation of primary trabeculae. So primary trabeculae are over the years, because of the constant pressure, the bone adapts, it models. And along this line of force, it develops more stronger scaffolding, and it is visible on an X-ray as lines on the X-ray. And in the line of the primary force is your primary trabeculae, and your secondary trabeculae are formed because of your body's reaction to the primary force. So it will be almost usually in the perpendicular direction of the force. So that will be the secondary trabeculae. So what happens in osteoporosis, you will have an accentuation of the primary trabeculae, where it will be more obvious to see the primary trabeculae on an X-ray, which usually in a young age individual, if you take a spine X-ray, it wouldn't be that obvious. And this will give you a vertically striated appearance of the body. Now, so these are the things how we use to diagnose osteoporosis. There are also a multitude of blood tests that are done to diagnose. As I told you, there are secondary causes of osteoporosis. Secondary causes of osteoporosis have to be ruled out before making a diagnosis of a primary osteoporosis. So secondary osteoporosis has a multitude of diseases that has to be ruled out by basic blood investigations. And if a secondary osteoporosis is there, it has to be treated for the disease, which will in turn treat your osteoporosis. Now, how do we prevent osteoporosis? Now, obviously, any of the secondary causes can be tackled. And if you give your body a good head start, which means if your peak bone mass is good, it will stave off osteoporosis for a long time and probably leaves you asymptomatic. It also involves adequate intake of calcium and vitamin D in your diet, weight bearing and muscle strengthening exercises, and exercises to reduce your risk of falls and fracture, which improves your balance. Then there are obviously avoidance of tobacco use and excessive alcohol use have been said to decrease the bone strength. And the indications for bone density tests are usually for age over 50 with any of these symptoms like backache, easy fractures, or mainly fragility fractures, would have to be screened for osteoporosis. Now, vitamin D deficiency is more prevalent in the older population, mainly because of inadequate sun exposure, if they are homebound and less outgoing, and in areas where, unlike here in India, where the sun don't shine. Now, how does exercise improve? So now regular weight-bearing exercises are defined as those in which your bones and muscles work against gravity as the feet and legs bear the body's weight. They include exercises like walking, jogging, tai chi, stair climbing, dancing, and sporting activities, yoga. How it does, it improves your agility, improves your balance, preventing falls. Then the pull of the muscles on the bone will make your body to deposit more calcium onto these weight-bearing areas and thereby enhancing its strength. Like I told you, the avoidance of tobacco and alcohol, it's strong. Tobacco has a detrimental effect on all the systems of your body, and it's not exclusive to the bone. It affects every system in your body, and it's a strict no. Excessive alcohol intake is also have been found to have detrimental effects on the bone health. Now, coming to the therapeutic measures, a brief outline, not dwelling too much into it. Naturally, vitamin D and calcium supplementation will aid in if your body has enough stores or enough levels of calcium and vitamin D reaching it, it'll have more chance of depositing on your bone and increasing its strength. Then estrogen and hormone replacement therapy. Then there are drugs which aid in the bone formation. That includes exogenous parathyroid hormone, which I've told you earlier was a gland situated right behind your thyroid gland, and it stimulates your serum calcium levels to increase. I will tell you how it works a little later on when I pick these drugs selectively. Then there are drugs that cause a decreased resorption of calcium from your bone. Those include calcitonin, bisphosphonates, and denosumab. Now, initially, we would all prefer non-pharmacological treatment, and specifically in postmenopausal women and or elderly individuals or senile osteoporosis, there might be other disease processes as well, and any reason to avoid an extra tablet or pill would be welcome. And therefore, non-pharmacological treatment is initially the what we aim for, but it is always not adequate. Like some people, even with their diets, where your calcium contributors like dairy and milk products, they will not still be getting enough calcium or vitamin D in their body. And people who are homebound, don't go out in the sun much, don't have enough exposure to sunlight, have low vitamin D, and there might be vitamin D deficient diets as well. Now, we already talked about the recommended dietary allowance of calcium. And in vitamin D, so this is specifically for older age groups, we aim to have of 800 to 1,000 international units of vitamin D per day. Now, that is always not possible with diet or even sun exposure, like you can see. So therefore, it might be supplemented through other means. And if you have vitamin D deficiency, which is below the 30 nanogram level, its treatment includes 50,000 international units weekly for 6 to 12 weeks, followed by a maintenance dose of 1,000 to 2,000. However, when you give vitamin D, it has to be known that the calcium levels in the body has to be normal. Therefore, vitamin D is usually supplemented with calcium to ensure that more calcium is not lost from the bone. Therefore, if your serum calcium levels are normal, then only vitamin D treatment will work. Unless if serum calcium levels are low, or if you have low calcium in your diet, it has to be supplemented along with vitamin D. Coming to the pharmacological therapy, and I'll be ending with the pharmacological therapy. I'll pick out these drugs which are commonly used for the treatment of osteoporosis, starting with bisphosphonates. So bisphosphonates, it's a wonder drug which used in a variety of bone diseases. They are analogs of pyrophosphates, and it mainly works by attaching to the bone remodeling sites, and it inactivates or causes apoptosis of osteoclasts. Apoptosis means self-destruction. So by clinging onto the osteoclast, it causes its own death, and therefore osteoclast, I told you the function was to take more more calcium from the bone. So by preventing that, it maintains your bone strength. So these are anti-resorptive therapy. The examples you include alendronate, ibandronate, zoledronate, which have specific dosing values. Alendronate is usually given at 70 milligrams on a weekly basis, and zoledronate is usually a IV infusion of 5 milligrams, which is usually taken monthly or 6 monthly based on the vitamin D levels. Next is calcitonin. Now, calcitonin, it's used in the treatment of women who have at least 5 years post-menopausal, and it's usually a single. It's used as a nasal spray of the dosage of 200 international units daily. And how calcitonin works, it also inhibits osteoclast development and activity and promotes osteoclast apoptosis. So this is also an anti-resorptive therapy. And the other function of calcitonin is these vertebral fractures, which are quite common in senile osteoporosis, senile osteoporosis and postmenopausal osteoporosis. It is used to alleviate the pain of vertebral fractures, which can be quite debilitating in old individuals. Coming to hormone replacement therapy, namely estrogen. Now, estrogen therapy is reserved for women who are unable to tolerate non-estrogen therapy. How does estrogen work? So, it inhibits bone resorption and increases your bone mineral density by binding to estrogen receptors on bone. And it blocks the function of specific cytokine that increase osteoclast formation. So, estrogen receptors are present on osteoclast forming cells. So, if estrogen binds to these receptors, it blocks the production of these osteoclasts. The deficiency of estrogen will have a free run on these osteoclasts to evolve and function, and thereby reducing and thereby absorbing more calcium from the bone. However, estrogen has to be carefully given in patients who have known or with suspected breast cancers or estrogen-dependent neoplasia or certain tumors. Coming to parathyroid hormone. So, parathyroid hormone is actually a normal hormone that is uh, secreted by our body in parathyroid glands behind the thyroid. And I told you how it functions in the body is it takes more calcium from the bone and increases your blood calcium level. So, but how does a parathyroid decrease the resorption of bone? So, how it functions is, if you give a continuous supply or a continuous dosage of parathyroid hormone, like how in our body it works, it functions the way I told you by increasing osteoclastic function and increasing the serum calcium level by taking calcium from the bone. However, if you give pulsed dosage of parathyroid hormone, how it works is exact opposite. Pulse dosage, it in fact does the opposite and induces bone formation by a mechanism which is still not clearly understood, and therefore that is how your parathyroid hormone treatment works. And this is mainly the drug is known as teriparatide, and it is a recombinant drug which is made, and the dosage includes 20 micrograms per day as a daily subcutaneous injection. Selective estrogen receptor modifiers are drugs which work similar to how the estrogen works. And the drugs example would be raloxifene, the dosage of 60 milligrams per day. And the other drug, which are over the last maybe 20 years or so, monoclonal antibodies have been designed for function for the treatment of a wide range of diseases. And monoclonal antibodies have been used also, specifically denosumab. It is an antibody which works on a ligand. I will tell you. So when your osteoclasts work, how they get is you have to get a signal to these osteoclasts to function. So these signals require an antenna. So the antenna is what it's called. It's a rank, and your signal is rankle or a ligand. So your ligand attaches to the rank and activates their osteoclast. So denosumab works by blocking it binds to rank L, and therefore it cannot function to activate the osteoclast. So these are the brief drugs. There are also a wide variety of therapy which are not streamlined or not used as mainstream treatment, but they have also been shown to have some good effect on the bone, especially a testosterone replacement, but it's not widely used and not recommended, and it has to be used in select patients for specific causes. A testosterone replacement therapy has been found to be of very good effect on senile osteoporosis in men over 70 years and above, to increase your bone strength and quality of life. So That's the brief outview of osteoporosis, and I hope you've taken some understanding and there would be some of help. Thank you.
Thank you, Doctor. The session is open for questions.
Can I go for the first question?
Yes, please.
Yeah, thank you. Doctor, one gap that I felt, usually we have a lot of ads coming online and even on TVs where there's a lot of boost on women drinks, health drinks, wherein they focus on calcium and vitamin, all that, vitamin D and all that. So what I wanted to know is the peak bone age is between 25 to 35, right? And then it starts deteriorating or there is a need for supplementation by 50. So what about the time gap between 35 to 50? How efficient is the absorption rate and how effective will supplements like the drinks that we have commercially be effective in reducing the same, reducing osteoporosis or deficiencies?
A good question, Harry. So, like I told you, 25 to 30 is usually when skeletal maturity is attained and peak bone mass is achieved. And following which there is a decline, even though it is a decline, it is not a rapid decline. It's just, as you've seen the graph, it's a slow decline over time. The decline takes a jump in post-menopausal women, usually around the age of 50 and above. That is when your estrogen in the blood is reduced, and therefore that is when the protective effect of estrogen is no longer there and the bone strength is lost. However, in individuals between the ages of 30 and 50, if you're saying, there are specific requirements of increased calcium or vitamin D, such as pregnant women, lactating women. Apart from them, and people who have adequate calcium and vitamin D rich diet would not require a regular calcium or vitamin D supplementation unless they have specific requirements. Like there are obviously like secondary causes or secondary diseases which have to be found, and that is a different thing. If an individual does not have any secondary causes of osteoporosis and has an adequate diet of calcium and vitamin D, and the food sources you all know what, they would not require an additional calcium and vitamin D supplementation. And this again has a lot of ifs and buts. Like if you are an office worker who does not see sunlight, naturally your vitamin D levels will not be adequate. But the immediately supplementation, rather than supplementation, your best thing would be to get sunlight. There is no harm in having these vitamin D supplements in regulated dosage. But if you take supplements which are off the shelf, which I'm not sure how much of the dose would be there, and that would be unregulated and it will not be even required.
Okay, thank you. I just have one more tiny doubt. Yeah. So again, after 25 years, and again, beyond 25 to 35 years, how effective will working out or, as you already mentioned, physical activity help in enhancing bone strength?
Yeah, a good question. So an active lifestyle is it leaves you with a better bone quality, bone strength. Apart from that, what it also does is it increases your balance and issues, and so therefore it prevents falls, which can later lead to fractures, fragility fractures. So exercise in an active lifestyle, like I mentioned, is um, it increases your bone to develop more strength. So something that is used more will require more deposition of calcium and vitamin D. More calcium, and therefore increases its strength. If the best example would be a person or a patient who's been lying or bedridden, he loses his bone strength by simply lying in bed. It's called or a disuse atrophy, where they start losing their bone strength. So exact opposite, if you have an active lifestyle, because you're using your bones more, your muscles more, it enhances your bone strength, which will give you, even though there is a resorption of bone with age, it will not be as quick, and therefore it can delay osteoporosis or even the onset of it. I think
Okay,
there
thank
are
you.
questions on the chat box.
Yes, there are.
So I have no idea what to say about these Ayurvedic products that come on the market, because I have no knowledge about that, and I cannot comment on that. So sunscreen lotion. So the thing about sunscreen lotion again, in sunscreen lotion is mainly used for the protection of UVA and B rays, to prevent skin cancers, or even the mildest effect of a suntan. So basically, sunscreen lotion, uh, it, we as in Indian population, we actually do not require a heavy application of sunscreen lotion unless you're out in the sun for quite long, prolonged periods, and because as such we have a higher percentage of melanin in our skin, which is naturally protective. The sunscreen lotion would be more efficient in people with less melanin, mainly the Caucasians, were fair-skinned individuals, and in them, their skin is being sensitive to UVAs and B rays, have to have an application of sunscreen almost all the time. Whereas us, we would not require it as much unless you're for working in prolonged periods in the sun, which can obviously have detrimental effect. The products for bone health, is there any specific product we're talking about? Or see, calcium and vitamin D supplementation comes in many forms. In fact, most of our foods are also fortified with calcium and vitamin D, and uh, they have given like a daily dosage of more than 4,000 milligrams is not required of calcium, as well as in vitamin D as well. There is no upper limit, which is saying as an upper limit of cutoff for vitamin D, but too much of a thing is never good. So I don't know if people who require it, who have no other sources of getting calcium or vitamin D in their diet, these supplements do help a lot, and there it is definitely helpful. I think this is a question for that should be answered from you. Vitamin D sources in diet. Vitamin D is in vegetarians is a deficient diet. So apart from fortified foods, your green leafy vegetables will not, that is calcium. Again, vitamin D per se, it's sun. Basically, go out in the sun. And specifically, it is the afternoon sun. So I know it's There are myths about which time the sunlight is good for vitamin D production, and it is actually your afternoon sun where it's actually quite uncomfortable to go out. But you don't require prolonged exposure, not hours together. Even 10 minutes of afternoon sun will have adequate vitamin D production on uncovered skin, mind you. If you're covered and go out, it will not work. So on uncovered skin, even 10 minutes of afternoon sun is actually quite helpful.
There is another question. Do you recommend exercise for an osteoporosis patient? From Idea Kerala chapter.
So exercises, the thing about exercise is if you are osteoporotic, the main thing is you have to be treated for osteoporosis. Once you have the treatment for osteoporosis, the next step is rehabilitation, which includes exercises. So immediately, if you are fragile, we would not recommend exercises like if they are unable to walk, or if they have back pain, or if they have any stress fractures, obviously exercise is not recommended at that time. Once you have taken treatment for osteoporosis, the next step is obviously in rehab includes exercises.
Good evening, doctor. I have a doubt. If you have a low level of vitamin D, doctors prefer either supplementation or some doctors prefer injection. Then how long we have to continue with this thing? Can you give me an advice, please?
So we aim to get around 30 to 40 nanograms per ml of vitamin D
Okay.
on the blood. So if you have very low levels,
Yeah.
the injection, what it does is it gives you a pulse dosage of 6 lakh units. They give an injection, an intramuscular injection, and that will give your body an adequate source of vitamin D to start with, and then it is supplemented on a weekly dosage.
Okay.
So that is one way to treat. So usually on an outpatient basis, where we see patients who are not admitted in the hospital, we do not prefer an injection to start with. These injections would be usually given to patients who have already suffered a fracture with low vitamin D or were admitted. And therefore, to alleviate that low vitamin D, we would obviously, as they are inpatient, we would give a injection vitamin D and supplementation with calcium. And if your vitamin D levels are not too low, or if there are no fragility fractures, we would recommend a weekly dosage of 50,000 international units over 6 to 12 weeks. Then it's followed by a maintenance dose of around 800 to 1,000.
Okay. Thank you, doctor.
I think we're done with the questions. Priya?
Thank you so much, Doctor. We are really enlightened with your knowledge and presence. Thank you so much.
I think those are very valid and good doubts, which, coming from a nice participation. Thank you for having me. I hope I've done justice again.
Thank you, Doctor.
Thank you.
Let me take this opportunity to announce the winners of the competition conducted by Department of Clinical Nutrition and Dietetics in association with Indian Dietetic Association, Kerala Chapter, Nutrition Society of India, Eat Right India, NetProfan, in connection with Rashtriya Poshan Ma 2021. Infographic poster competition winner on topic triple burden of malnutrition, way to combat hidden hunger are the first prize winner, Fatima Bevi from first BSc Nutrition and Dietetics, St. Teresa's College. Second prize winner, Elvina Thomas from first year BSc Nutrition and Dietetics, St. Teresa's College. Third prize winner, Josna Justin from first BA Economics, St. Teresa's College. Healthy diet preparation filled with millet. Winners are first prize winner, Ifa Imran from third HSC, St. Teresa's College. Second prize winner, Shreya Valsalan, first BSc Zoology, St. Teresa's College. Third prize winner is Merin Deepan N, BSc Mathematics. Hearty congratulations to all the participants. May I invite Dr. Samja Sabu, faculty from Department of Clinical Nutrition and Dietetics, for delivering vote of thanks.
Thank you, Priya ma'am. Gratitude makes sense of your past, brings peace for today, and creates a vision for tomorrow. Namaste and good evening to all. It's an honor to express my gratitude to all who are present here for this national webinar on Take Action for Bone Health, organized by Department of Clinical Nutrition and Dietetics in association with Indian Dietetic Association Kerala Chapter, NetProf1, Nutrition Society of India Kochi Chapter, and Eat Right India. Let me first of all start by giving glory to the Almighty God for His blessings, which made this event possible amidst the prevailing circumstances of uncertainty and distress. I pay due respect and gratitude to Reverend Dr. Sister Vinitha, Provincial Superior and Manager, CSST, for being the endless support for all our activities to make them successful. Thank you, Sister. I am expressing my sincere gratitude to Dr. Sister Emmeline, Director, for her boundless support for each and every activities of our department. Thank you, Sister. I'm extremely thankful to Dr. Lissy Matthew, Principal, St. Teresa's College, who always stand by us for materializing all our ideas into reality. Thank you, ma'am. I extend my profound sense of gratitude to our Honorable Chief Guest, Dr. Ronsi Xavier Kuruvilla, Assistant Professor, Department of Orthopedics, CMC Vellore, to take out time from his very busy schedule to grace the event. His session helped to impart new knowledge about the importance of bone health to each one of us. Thank you so much for your session, sir. I extend my sincere thanks to Mrs. Lekha Srinivas, Women's Studies Center Coordinator, for being the pillar of support and going the extra mile to keep WSC in a remarkable position in this prestigious institution. Thank you, ma'am. I place on record of heartfelt thanks to Mrs. Annie Thomas Thotan, Head, Department of Clinical Nutrition and Dietetics, for all her tireless efforts to make all our ventures successful. Thank you, ma'am. I must thank the organizing team, volunteer for working hard for the past few days to make this webinar successful. I congratulate all the winners as well as the participants for their active participation. Thank you everyone once again for making it a great success. Thank you.
Thank you, Samja. Participants, kindly fill in the feedback form to avail the e-certificates. We are concluding the session. Thank you for the participation.
Thank you, ma'am.